Welcome to 10 Minutes with Harry. With dual chamber pacing, we not infrequently see rapid ventricular pacing, which is very hard to interpret. In most cases, this is due to a run of a supraventricular tachyarrhythmia followed by the pacemaker. Today, I'm going to show you another cause of this, which is called pacemaker-mediated tachycardia. When one does a pacemaker Holter monitor, we often see brief, rapid, inappropriate ventricular pacing and wonder what is the cause of this. In most cases, of course, it's going to be short runs of supraventricular tachycardia in patients with a dual chamber pacing system. Here is such an example. We can see with the red highlight that there is atrial sensing, a sinus P wave, followed by ventricular pacing. And then there is the onset of a rapid tachycardia, clearly with pacing, and therefore we are assuming that this is a supraventricular tachyarrhythmia. When one looks occasionally at the Holter monitor report at the mean heart rate histogram, one sometimes sees rather frightening rate changes that occur throughout the tracing. You can see that the upper rate is set at 150 beats per minute, and for probably close to 50% of the time or more, the pacemaker is running at 150 beats per minute, whereas at other times it's at 70. And there is often a sudden onset from the low rate to the upper rate. This may be caused by a pacemaker-mediated tachycardia. This is a pacemaker endless loop re-entry tachycardia. It occurs with patients with dual chamber pacemakers and having retained retrograde conduction. The anterograde limb is the pacemaker, and the retrograde limb is conduction back to the atrium from the ventricle with atrial sensing outside the post-ventricular atrial refractory period, or the time when the atrium, the ventricle is refractory. Apologize for that. I meant to say the atrium is refractory. Here is such an example of a pacemaker-mediated tachycardia or a pacemaker endless loop re-entry tachycardia. Here one can see atrial sensing and ventricular pacing. There are also spontaneous beats, which may well be ventricular ectopics. And then suddenly, while the ECG is being taken, in V1, we have the onset of a tachycardia, which continues on and on, an endless loop. Historically, endless loop tachycardia were recognized in early, minimally programmable VDD models. These were implanted in the young with high degree atrioventricular block. And because they were usually minimal programmability, even VVI could not be programmed. And as a result of that, the endless loop just remained. You have to have a retained retrograde conduction to set up the endless loop, even though there is anterograde block. There was no way of treating this, and it was also present in early DDD models, but now pacing options were available by programming, and we could go back to ventricular VVI pacing if necessary. The causes of an endless loop re-entry tachycardia are atrial and ventricular ectopics, intermittent loss of atrial sensing or pacing, magnet removal, a long AV delay or algorithms that extend the AV delay, and a short post-ventricular atrial refractory period so as to allow sensing in the atrium outside this blanking period. Let's have a look at atrial ectopics. Here we can see a rhythm strip where at the beginning we can see atrial pacing and ventricular pacing. The red arrow with the yellow highlight shows an atrial ectopic with an inverted P wave, and this then sets up the endless loop tachycardia. Here is another example, this time with atrial sensing and ventricular pacing. We have the red arrow showing the retrograde or the inverted P wave, which is an atrial ectopic, and then this sets up the endless loop tachycardia. And in this example, one can easily see the P waves that conduct to the ventricle. Here is another example with a ventricular ectopic. We can see atrial pacing and ventricular sensing. There is a rate of 1,000 milliseconds or 60 beats per minute. There is a prolonged AV delay or period from atrial pacing to ventricular sensing. We now have a ventricular ectopic. Within that, one can see the retrograde P wave going back to the atrium. And then after a long PR interval or AV delay, it then has a ventricular paced beat. And then you can see a retrograde P wave. And again, with approximately 400 millisecond AV delay, and it sets up an endless loop rhythm, which is just below 100 beats per minute, and therefore we cannot call this a tachycardia as such. Historically, we had a very few treatment options. We could put a magnet over the pacemaker, which is what I used to do to make it VVI. We could block retrograde conduction with beta blockers and verapamil. We could do a His bundle ablation to prevent retrograde conduction. But these pacemakers were present at a time when His bundle ablation was a very significant procedure and not like it is today, and one generally avoided doing it. And as a last resort, we replaced the VDD pacemaker with VVI. Today, we have many programming options available. We can correct the cause, the atrial sensing or pacing issues. We can program DDI, AAI, or VVI pacing. The most common way is to prolong the PVAP and even shorten the AV delay. But we have now algorithms to terminate the tachycardia. Let's have a look at this. Today, because these algorithms correctly terminate these tachycardias, they are no longer endless loop, and therefore we call it pacemaker-mediated tachycardia. There are two types of algorithms available. The first is a prevention one with extension of the PVAP after a ventricular ectopic, so as to prevent the ventricular ectopic from setting up the tachycardia. We also have detection and intervention algorithms. Here is an example of this. We can see atrial pacing and ventricular pacing, and then there is a failed atrial pacing. As a result of this, There is a retrograde P wave, which can be seen with the red-yellow highlight, and this then sets up the tachycardia. It's set up for a number of cycles. Each company has a different number, but one cannot look at an ECG and necessarily correctly determine the company, because it takes time for the pacemaker to determine that this may be a tachycardia, and then it counts a set number of cycles, and at the end of that time, PVARP is extended over one cycle, terminating the pacemaker-mediated tachycardia. So what have I learned today? A pacemaker-mediated tachycardia is actually an endless loop re-entry tachycardia in patients with dual-chamber pacemakers and retrograde conduction. The anterograde limb is the pacemaker, whereas the retrograde limb is conduction to the atrium with sensing outside the PVARP. There are numerous precipitating factors, including ectopy and pacing or sensing failure. And today there are a number of programmable options, including algorithms, to prevent or terminate the tachycardia. Thank you.